for joining us again. My name is Julie Soukup with the Medical Memory, and I'm excited to have another episode of Take One Patient. It's a great resource now that we're starting to look at virtual and recording and all of the things to talk about patient communication and communication excellence. I'm very excited to have Dr. Ronnie Strickland join me today as far as working with Cardinal Health. Hi, Dr. Strickland. How are you?
I'm doing well. How about yourself?
Great. So I think what would be most useful to start is actually for you to talk a little bit kind of about your background, starting in as a pharmacist and starting in that capacity, and kind of how you got into more of an operational role with Cardinal and what you're doing now.
Sure. I'm a 1992 graduate of Campbell University School of Pharmacy. I do have a PharmD degree. Worked the first part of my career in a retail setting and moved up into operations management there. And, things just got to the point where, the retail grind kind of got to me. So I went back into a hospital, which was my original love. I actually worked my entire pharmacy career during the time that I was in pharmacy school in a hospital pharmacy. So I moved back. Worked my way up through operations, and I was actually a pharmacy director of a small rural hospital, licensed 100-bed. We had a 50-bed nursing home that was owned by the hospital. We also had 12 physician clinics that we owned, and this was back in the early 2000s. So that was kind of a novel approach at the time. So I know there's a lot more of that goes on now, but back in the early 2000s, it was not very common for health systems to own physician clinics. So, as we move to advance our pharmacy practice there in the hospital and increase the offerings, one of the things with us being a small rural facility, we closed at 9 p.m. at night. So I started investigating, some type overnight order entry company or contract that we could get into so that our patients would be covered by a pharmacist review of medications 24 hours a day. At the time, that was just beginning. We were just starting to get into, the full electronic health record. And so, in order to have a true electronic health record, you need a true 24-hour electronic medication administration record. So in order to do that and do it correctly, you need a pharmacist verifying orders. So we went through, the different companies that were out there, Cardinal Health being one. I actually had several friends that worked for Cardinal at the time, two of which worked in the remote pharmacy services business. So I felt like I had a pretty good connection, into that operation. The interesting thing was that we were managed by a larger facility, about 35 hospitals across the Carolinas and also down into Georgia at the time. And so they kind of forced me to utilize their in-house service and utilize one of the 24-hour hospitals over at the in one of the larger cities. I'm not going to call any names, but it was certainly one of the larger cities. And we did that for a little while. It didn't really work out all that well. Obviously the pharmacist on site at the hospital, their main focus was the large number of patients that they had in their facility. So we ended up switching back and going to Cardinal, and through the chain of events that occurred, and I ended up with Cardinal. I actually started working as a staff pharmacist with the remote pharmacy services team based in North Carolina, worked my way up through team director, regional director for the East Coast, and then my current role, and I've been in this role for almost 3 years now, is National Operations Director for Cardinal Health's remote pharmacy services business. So it's a little bit of background about me.
Yeah. So one thing that is interesting that I didn't really realize is just what you started talking about, and in case other people don't really understand, is talking a little bit about the verification with a pharmacist when there isn't a pharmacy open or right there, and so
Sure.
talk to a little bit more about like what that need is and how that kind of comes based on the pressures that we're putting on nurses at that time and the challenges that why there's a need for a remote type of service that allows for that.
Yeah, Julie, you hit the nail on the head. It's very important. Most of your regulatory agencies or your accreditation agencies for hospitals, they require the same level of care, 24 hours a day, 7 days a week. So what would happen when our pharmacy would close at night? Our automated dispensing machines, and you may hear me refer to those as ADMs moving forward throughout the conversation. They're placed on override, and the nurses actually would just, the requirement, if they had something that needed to be administered during the night, they would go in, override the medication, and they're putting their license at risk on verifying that, hey, there's no drug interactions, there's no allergy interaction, there's all of this is fine, I can do this, and I can administer this to this patient safely. So what having an overnight order entry service does, it takes that burden and that onus off of the nursing staff, and it puts it on a true pharmacist. And the nurses are able to, pick up the phone, call if they have a drug information question. Physicians are able to call if they have an interaction question or any question about a medication for a patient. So it's really, putting that responsibility back where it should be, and that's on a pharmacist. So you have that pharmacist 24 hours a day, 7 days a week, 365 days a year. So
Yeah. Well, and that's what's interesting is when we first spoke about it, it was just that you said, I mean, now you have a nurse that's doing a night shift, is already a
yep,
little shorter staffed, is maybe a little bit tired or whatever, that is now all of a sudden needing to have, a pharmacy, there needing to be a pharmacist also. And just the
right.
small little pieces that can evolve from that. Which is not even losing your license or his license, but also like the impact on a patient, because if the provider's saying, hey, you need to administer this, well, they're going to administer it, and so it's definitely kind of like brings about like a wow, there's a challenge in this system, especially in more rural more hospitals that don't have as much staff, issue that you guys are really truly solving in that complexity or in that piece.
Absolutely. Yeah, I mean, and the thing that we need to keep in mind, in society today, we have more and more and more healthcare professionals. I'm not just going to say nurses, it's also pharmacists, it's also physicians that are being, criminally charged for medication errors.
Yeah.
And we follow, one of the things that I am big on is I follow a just culture. Yeah, and when you have a system where a nurse is having to make a decision on, is this medication safe for this patient, then you have a system that is set up for error. So by not having some type pharmacy service 24 hours a day, whether that be remote or whether that be on site, you're really, you have a system that is setting people up for failure.
Right. Well, and that's one of the things we had talked about too is, COVID shifted a lot of things in a really positive way where now, the resources are there as
Yep.
far as tech wise, even functionally wise, to be able to better educate patients. Also, medical memory, we do a lot with educating patients, even sometimes, sending videos on behalf of the pharmacist, on behalf of the pharmacy, on behalf of the provider, just on the education side of it, but also the ability to get this like virtual support for nurses that may not understand it or need to like have that, stop put in place virtually, So how is even that ideation that you have really shifted to that virtually since COVID?
Well, one of the things that we've seen, and years ago, our bread and butter customer was that small rural hospital, 50, 75 beds that really couldn't afford to have 24-hour pharmacy on site. So, one of the and we really went after and marketed to that customer. Well, COVID, really changed the insight or the thought process of people. Not only, I mean, prior to COVID, how many patients did you know that had gone through a telehealth visit with their physician? Very few. It was out there. The technology is available, and some places were using it, but it was not widespread. Well, COVID actually really drove home the point that this is a successful model, and actually it's probably a little bit more safe because you can take a 10-minute conversation with a physician, and you're not having to go through the physician office, you're not having to go through all of that. And it's driven home the fact that, hey, we can practice medicine safely from a remote standpoint. And we've started to see that more and more state boards of pharmacy are addressing remote pharmacy services.
Yeah.
They're addressing work at home versus work from a licensed pharmacy. They're addressing, the entire model that we practice.
Yeah.
One of the good things regarding, the company that I work for, we actually started this business concept back in 2003.
Yeah. Wow.
My previous boss actually worked with ASHP and co-authored, ASHP's guidelines
Yeah.
on remote pharmacy order processing.
Yeah.
So,
Well,
but
and that's what we're even seeing, a lot on our side too, of course, using video to educate patients or any of those things
mhm,
is providing that medium in one of two ways. Either we are seeing some of our hospitals where they're just really busy during the middle of the day. They're wanting to have these bed to med conversations or these bed to med explanations of medications, but to pull away from all the other things is just not as doable. So being able to even send a one-way video, a video message that they can watch again and again and be able to understand their discharge medications, what they're supposed to do, all of those things can have an incredible impact without having to take the time to go to the hospital and go to each one of those things, which all those pieces of time really add up. Even if it's just having the hi, how are you, and walking to the floor, is how can we start to maximize, you talked about the you always want them to be at the top of their clinical skills. How can we maximize, those conversations or those educational pieces to provide a patient to have that information, re-understand it, but also to ensure that they're being safe, in that piece with what you're talking about with a lot of these places where it's closed, where they can have, all right, I need to talk to an ER doctor, or I need that flag video sent to me that says, hey, there's a problem, too. And I think that was interesting how you had said that of you want them at the top of their list, the top of their clinical skills.
right.
How can we cut down the times of the non-needed things by providing that their ability to do that virtually,
Right. One of the things that we're doing currently, and we actually have a customer actually here in North Carolina, and we've done some Becker's webinar presentations with that pharmacy director there. But they saw a need, in hospitals. CEOs, they deal with decreased CMS reimbursement, due to their readmission rates. Well, this particular hospital had, their CHF readmission rate was pretty high, and they were getting substantial penalties on their CMS reimbursement. So they reached out to us, and one of the things that we did, we're during the day we're processing, or verifying, probably 50% of their orders that come in.
Oh, wow.
And what they've done is they have, decentralized a pharmacist, and that pharmacist is actually doing discharge counseling for patients that are leaving the hospital, and covering their medications, and making sure that the patient knows exactly what medication that they need to continue or they need to discontinue, or things that they need to start. And not just that process, but they've also done some other things with nursing. But they saw a 65% reduction in their CHF patient readmission rate.
Wow.
So, they've been able to cut down on that CMS penalty and, increase their reimbursement, while also, providing another patient safety mechanism,
Right.
to the patients that are being discharged.
Right.
The most confusing thing for patients going home is, what medications do I start? What medications do I continue?
Yeah.
But more importantly, what medications do we stop?
Yeah.
One of the things that we've seen a good bit, and most hospitals do these, you do therapeutic substitutions. There may be 6 drugs in one class, and I'll give you the proton pump inhibitors. Most hospitals use one. Well, when the physician is doing the discharge list or the discharge med list, they may not indicate on there for the patient to stop. Let's say it's Protonics now.
Yeah.
Okay,
Right.
so then the patient goes home and they're taking Protonics, but they're also taking the other proton pump inhibitor
Yeah.
that they were on before they came in. So that really gives the pharmacist the opportunity. And, and we all know the pharmacists are the medication specialists.
Yeah.
It gives them the opportunity to
Yeah.
spend the time with that patient and really make sure that, their medication list for patients going home is accurate and the patient understands what they need to do.
Yeah.
So,
Absolutely. Well, and we're seeing that with quite a few of the hospitals that Medical Memory is working with too, because that conversation is so vital and so important, because also your discharge, you're not really sure what you were doing. And a lot of times the patient isn't really the one that's like caretaking this. So even if, they're getting home and sister's helping or brother's helping the other day or wife isn't there, that's where they started even recording a lot of that information, because they're like, hey, just so you know,
absolutely.
recheck this, share it, and leveraging, the tools that are available for that patient education, because to prevent that. Because I remember you saying that it was like 75% of patient safety issues or challenges with that are medication related, with like taking the wrong thing or not taking whatever it might be, which is crazy to think about, especially as it relates to preventing those readmissions back in.
Right. Yeah. And, we have a breadth of data that is available out there. And we processed north of well over 8 million medication orders last year. And, about 3% of those are actual things that we had to intervene on. Well, that 3% worked out to be, and I've got that number right here, 255,000 clinical interventions that were performed by a pharmacist. And of those, what we found, and our data supports, that half of that number is, a patient safety concern on those interventions that we did.
Yeah.
So, that's over 125,000 potential medication errors or medication events that could have taken place just in the past year with the hospitals that we covered.
Wow.
So,
well, and that takes
significant.
that onus off of the nurse or any checkpoint, even if it's a pharmacy, as you were talking about, of saying, let us do this work of it so you can get out to patients and educate and communicate, or also you have this fail safe, umbrella in case, it's 2 a.m. and you're not reading it right. Nurse, that's
Right.
not a specialist here. Wow, that's a lot. That's a lot of people. And gosh, 250, you can think about it, it's 255,000 people, if some probably are doubled, but, and
it's significant.
Things.
Yeah, it's very significant. And having, some type of, whether it be remote or whether it be on site, but we what we do is really, we can free the pharmacist up in a side-by-side situation where, we may be working during the day and that pharmacist is able to go up and do clinical rounds. They
Yeah.
are able to go up and have that patient interview at discharge, or even have that patient interview on admission as well.
Yeah. Yeah.
So, for med reconciliation, I
Yeah.
mean, you know, med reconciliation, and it's something, and it's a program that we're working on right now as well. Really being able to do patient intervention via video
Yeah.
at the admission to the hospital, or even while the patient's still in the emergency room.
Yeah.
We all know that if we're not getting accurate medication lists when they come into the hospital, then everything's going to be inaccurate throughout their entire hospital stay. So,
Yeah.
very important to address the situation, or to address that patient medication history at the start or at the onset of their hospital stay. So, very
Right.
important.
No, absolutely. Well, awesome. I mean, I really appreciate kind of what you guys are doing and that extra support. I know even a lot of my nursing friends, to think, I know that whole case that came up at Vanderbilt really scared everyone of she misadministered or something. And I think you already, we're working on and solving that challenge even before it hit, so that, we're already asking our nurses to do so much, or more with less, or even our pharmacists to do more with less, that, providing some of these services to take that onus off to go into where they went into it, which is patient care, patient communication,
You're absolutely
is
right.
really supportive,
Right. Patient
Awesome.
safety is a huge, it's a passion of mine. I actually had to deal with a medication error that resulted in a patient death. Um, it happened at a location that I was working at, and I was the pharmacy manager. And having to sit down and have that conversation with that patient's family, that, hey, a medication error resulted in this death. So it's very important in patient safety. I remember reading "To Err Is Human," the IHI report that came out back in the 90s.
Yeah.
And it's absolutely amazing, the number of mistakes. And I mean, some of the things that you don't realize that are medication errors.
Yeah.
Let's say a patient is supposed to get a drop in their right eye, they get it in the left eye. Technically, that is a medication error.
Yeah.
It's
Yeah.
administered at the wrong site.
Yeah. Yeah.
So, anything that we can do to improve patient safety in a hospital setting, because patients are at our mercy in an acute care or a long-term acute care setting. So it's very important for us to put all the mechanisms in place that we can to protect those patients and make their stay as absolutely safe as possible.
Yeah.
Remote pharmacy services can certainly do that. We can, we've expanded beyond just overnight. I have pharmacists. I have about 175 pharmacists that work for me. Part of them work during the day.
Yeah.
Not all of them work overnight, and they
Yeah.
work side by side with some of the pharmacies and in hospitals that we work. So,
Right. Awesome. Awesome. Well, thank you so much for joining me and kind of educating, especially me, about some of these places, and how the virtual aspect is really, really available now, in a lot of facets that people don't think of. So,
you're absolutely right.
specifically in patient safety and medication. So I appreciate your time, and thank you so
Thanks,
much.
Julie. And I have certainly enjoyed it, and I appreciate you giving me this platform and this opportunity to talk about my passion, which is patient safety.